راح نفتتح اليوم بفعاليات جراحة العظام والسيشن أكيد راح يكون very interesting because we have international and local speakers who has got high value and they are well known and renowned as key figures in their specialty. So I would ask the moderators to start the orthopedic session. وبس تنويه من اللي حكينا عليه امبارح انه we have to fill the pre-course or the pre-session evaluation which is available on the website. وما تنسوا بعد ما يخلص كمان session please to fill the post session course evaluation in order to have the Royal College accreditation and CPD points. وشكرا جزيلا.
السلام عليكم صباح الخير الجميع. We are happy being all together here for this conference and we'll be starting with Dr. معتصم المعايعة. Dr. معتصم المعايعة is a spine oncologist, orthopedic surgeon as a primary specialty. He is working in University of Miami health system, and we'll be talking about predictive analytical and decision making in management of metastatic tumors of the spine. Welcome, Dr. Mu'tasim, and we are so much honored having you here in Palestine as a brother and as a colleague. And actually it's happening that Mu'tasim is a brother of my colleague at the university, Dr. Muhammad Maaya, and so I'm so much happy having you here. Welcome, please.
Thank you. Sabah al-khair. Thank you, Dr. Khalil. Sabah al-khair al-jamia. I'm really honored and privileged to be here with you guys in Palestine. I enjoyed the first day yesterday, and I thank you guys for inviting us and having us with you here. Again, it's an honor. Again, my name is Mu'tasim al-Ma'aya. I trained in spine and musculoskeletal oncology, and right now I practice at the University of Miami for the last 8 years. What I do mostly is spine tumors, but I do a little bit of everything in spine, degenerative, deformity, a little bit of pediatric scoliosis. Up until last July, I also used to do a little bit of peripheral tumors, musculoskeletal oncology, but starting July 1st, I was exclusively spine. It's just too much to do everything, so I wanted to narrow down my practice. These are my disclosures, and you know, all respect to the whole committee, but I have to extend my special thanks to Dr. Mazen Abdullah for the invitation first, for the hospitality. We really appreciate everything. Same goes to Abu Mazoud. Thank you for all what you're doing for us. Yesterday was a special day for me. This is, to me, a special memory. It goes into a long-term, hopefully, relationship. So this topic is a little bit complicated. I will try my best to simplify things. When we're dealing with spine tumors, we really need a classification system or a roadmap to help us with basically two things: what to expect, what to predict if you do something to the patient surgically or if you don't. And to be able to figure out what to do, there are two major classification systems that have been published over the last, I want to say, 20 years. Those are classified into two things: either a principle-based decision-making or a prognostic factor decision-making classification system. And there is a difference. So we will explain a little bit more about how do you manage a patient with a known primary cancer who presents with a spine lesion, whether or not you have a biopsy and a histology confirmation that this lesion is from the same primary cancer. Then over the last 5 years, I want to say, a lot of good researchers in spinal oncology developed something called machine algorithms, which led into data predictive analysis. Basically, the more you do, the more you gather information from multi-centers. You feed it into a software computer system, and then this software can predict for you what would be the outcome with the data that you feed it. Obviously, this needs a lot of data so that the prediction can be as accurate as possible. So this is still in the works. It's not done, but it gives you a good idea how to do that. Obviously, this is a continuously advanced field, and there is a lot of future directions. We're going to talk a little bit about biologics and how biologics play a major role and the long-term outcomes. So let's start with simple things for the medical students. Spine tumors are mostly secondary, metastatic disease. There's only 5 to 10% that are primary tumors. And if you think about it, this is good, right? Primary tumors usually are, they have worse clinical outcome in general, and the prognosis usually is not that good, with few exceptions. Now, why is this significant? Because the spine is actually the most common site for skeletal metastasis. So almost always, if you have a stage 4 cancer, you're going to find a spot or a lesion in the spine, and then you have to deal with it. Now, over the years, there has been a lot of advances in systemic therapy, so immunotherapy, biologics, radiation therapy, so stereotactic radiation is here, proton beam radiation is here. That helped us a lot over the years, but that also put a lot of pressure on us as surgeons to do more, to do better for patients. So if the immunotherapy, chemotherapy, radiation is working, it's extending life expectancy, then we cannot just watch as surgeons. We have to do more. We have to be better at providing better quality of life. Now, we're not going to change we're not going to cure the patient, but we can improve the quality of life for whatever number of years is left for those patients. So again, it's a continuously developing field. As we know, these are the common primary sites. We see this in clinic over and over again. Breast, lung, prostate, breast, lung, prostate. Every now and again, a little bit of renal, a little bit of colorectal, GI tumors, and then thyroid. The primary site where those tumors go to, if you think about the anatomy, it's the thoracolumbar spine usually, and mostly the junction. Lower thoracic spine, upper lumbar spine, the blood vessels, the vascular anatomy, that's where they usually end up. That's what we see, I want to say, 70% of the time. Maybe a little bit less, but that's usually what's common. Again, what is the goal of management? You want to maximize the quality of life. This is a stage 4 cancer. You're probably not going to cure this, with a few exceptions. Now, they're doing really well with biologics, but we just want to make their life better. So we can make a difference. So you can provide pain relief if there is instability, and instability pain in the back is really bad. You can improve or maintain neurologic function, so they're not paralyzed, they're not completely dependent and bedridden, and you can restore or maintain the structural integrity of the spine. So the alignment of the spine. If you have a bad tumor that's destroying the posterior element, the stabilizing elements, and the patient is going into kyphosis, so they're walking like this, okay? Significant back pain, they can't walk for far, they're dependent, they need assistive devices. So you need to make sure that you are restoring the normal alignment. And by that, I mean the sagittal alignment, okay? So when you do on an x-ray the C7 plumb line, you improve that within 5 centimeters, and that has been shown to improve overall status, functional status, if you improve the sagittal alignment within 5 centimeters, okay? This is a multidisciplinary approach. I, by myself, will not make a difference. The medical oncologists by themselves, they cannot, and same goes for each specialty. And that's why I never make a decision without going back to these specialties. If I get a patient that was sent to me from a primary care, for example, because they saw something, my job is to make sure that I get a diagnosis, I send them to a medical oncologist, and we sit down and we discuss and we make a decision. Right now at the University of Miami, we have a sarcoma tumor board. We meet twice a week, Tuesdays and Thursdays. No decision is made on any patient by a single specialty. It has to be everybody. Andrew is with us all the time. He provides his pathological background, which usually gets us in trouble, but we appreciate his experience. Medical oncologist, radiation oncologist, it's a team approach. It's a team approach. I have been trying also in the last 5 years to establish a spine tumor board just to look at spine cases specifically, and we get a good volume of cases, and that's still in the process. But the concept is the same. Concept, multidisciplinary approach. Now at the beginning I said there are prognostic classification systems. Those are the ones that will tell you what is the life expectancy, how much this patient, how much time do they have. You know, الأعمار بيد الله, we know that. But these, they you know, evidence-based, they give you an idea about life expectancy. That's important, but that's not enough. Now, stereotactic radiation, since that was developed about 15 years ago, again, a lot of advancement in the field. Minimally invasive. So when you have a spine tumor case, it doesn't mean that you have to do a wide open, morbid procedure. And sometimes patients don't come out of this. They die on the table and all of that. Now we have a lot of minimally invasive approaches, and I will discuss this later. And the last important thing is the evolution of target therapies, the biologics, the immunotherapy. Those are really good in certain cancers, but they're very expensive. As we were discussing with Dr. Mayil Kele yesterday, we're talking about $250,000 per year per patient for biologics, for immunotherapy. So it's really expensive. It doesn't work all the time. So if you can afford it, yes, human beings, right? So, but it's tough for, you know, countries with financial difficulties. It is a problem. So this is a summary of all the publications that looked into prognosis and prognostic factors in spine tumors. The most commonly used are Tomita and Tokohashi, and Tomita revised his classification system, and Tokohashi revised his classification systems. I personally like those two the most because they're easy to remember. They look complicated, but this is equivalent to the Merrill score in tumors and another system that we're going to talk about. So basically, they look into how many metastatic disease is present in the spine or outside the spine, et cetera, and then you get down and you calculate the points, and that will give you roughly an idea about the life expectancy. In general, if the life expectancy is less than 6 months, we don't really like to do surgery, with some exceptions. Those patients are hospice patients. You provide palliative radiation, and that's about it. Again, this is not a Quran or a Bible. It's not. It's just a framework. Now, over the years, you know, newer classification systems, the New England Spinal Metastasis Score, the SORG as well, and we're going to talk about them in a little bit. Again, this is only prognosis, okay? So, in 2019, the SORG people, they introduced the concept of machine learning algorithms. Again, as we said, this depends on what data you feed. So that means, you know, the more you do, the more information you get. You feed the software, and then, you know, it potentially will help you in the future to predict the prognosis, for example. Those are very good studies that looked at the 3-month and 1-year mortality and morbidity in patients with spine tumors. The bottom line is, when you see a patient that's cachectic, so sarcopenia, they're not doing very well nutrition-wise. Don't push it. Don't try to be a hero. Oh, I'm going to help this guy. Guess what? You're going to get in trouble. The data supports that. You're going to get all the side effects, the complications that we know about, from infection, etc. That's why every cancer patient in my clinic will get a full workup, nutrition-wise, albumin, protein level, all of that. And whatever we can improve, we start right away, right? So protein shakes, whatever, just provide them with better nutrition. That will affect your wound healing. And there's nothing worse than infection in a patient with cancer. That delays their chemotherapy, it delays their radiation therapy, so it becomes way more challenging. So what is the limitation of those prognostic factors? They didn't give us, what do we do exactly? All they did is, what to predict. How long are they going to live? So that's not enough. Okay, what if somebody scored very low and their survivability is like more than a year? So what do I do? So that prognostic classification system did not help you. It only provided you with how much time do they have. So there is a need for other systems to answer these questions. Not only do I do surgery or not, do I do it open or minimally invasive? MIS is minimally invasive spine surgery. Do I instrument or not? Do I put screws or not? Where do I go? Do I go posterior? Do I go anterior? Do I go combined? Do I put implants anteriorly? Do I cement my screws? And since 2017, we had fenestrated screws introduced in the market. I was involved in one of the systems that helped with that. Because before fenestrated screws, what we used to do is, for pedicle screw insertion, you do your probe and you make your hole in the pedicle, and then you quickly mix your cement and you put it with a cannula, and then give me the screw quickly. Oh, it's too late. Now the cement is hard. I cannot do it. You ruined this. Now you just put the screw and you put the cement through the screw. You can have all the time, no rush. If the cement gets hard, you can mix it again, not a problem. So that provided a lot of benefit for us. Again, there are some side effects, complications, cement leak, etc. But as long as you're aware of all of this, that minimizes the risk over time. So we get to the principle-based decision making. This is something that I go over with the resident and the fellows every day. So when I am in the OR doing a case and the junior resident on the floor gets a consult, they go to see the patient, they freeze. Oh my God, spine tumor, what do I do with this? They keep coming to the OR while I'm working and bug me. Don't do that. There is publications right there. Very simple. It tells you exactly what to do. You can almost always make a decision and manage the floor patient and get what needed until I finish and come and discuss the case with you. So the NOMS criteria, those are the Sloan Kettering group, Mark Bilski and Ilya Laufer, back in 2012. When I was a fellow, I did a month with them at Sloan Kettering for spine tumors. They were still developing this system. And I was like, this is really helpful. And they, ultimately they published this. Most spine tumor attendings in the US follow that. But again, this is only a roadmap. It doesn't give you 100% of the answers. It will probably give you 90% of what you need to manage. Later on, Pat and Edal, they wanted to revise that, and they said, you know what, NOMS is great, but it doesn't explain everything. For the resident, I really want them to understand what is NOMS. N stands for neurologic examination. O stands for oncologic assessment. M stands for mechanical stability. And the S is systematic status, basically prognosis. So you need to go over 4 of them before you can make a decision. Now for the N, it's 2 components. Your neurological exam. You go to the patient, you examine them, muscle strength in all major muscle groups in the upper and lower extremities, sensation, reflexes, Babinski sign, right? Make sure they don't have any pathologic reflexes, no signs of myelopathy, rectal exam and sphincter tone, and then you document your exam. Then the second component of the N, which is the neurological evaluation, is image-based. So the resident, if he knows this, he will tell them, do I have an MRI? I need an MRI. And the only thing that I need is a T2 axial cut. That's all I need to come up with something called the ESCC, the epidural spinal cord compression scale. That's why you need a T2 axial MRI, okay? If they don't do anything else and they do this, it's enough. The technician in the radiology department is in a rush. They give you bad quality image. Tell him, I don't care about anything else except a T2 axial. That's all I need to know. What is the relationship of the tumor? Okay, T is for tumor, to the spinal cord, and how much compression is there. So this, again, was published back in 2011, I think, or 13, and this is what you need to know. This looks very complicated. I'm like, where's the tumor? Where's the spinal cord? Where's the CSF? I cannot tell. I really don't care about 1B or 1C. I only care about 2 and 3. And those are the advanced compression of the spinal cord. There have been many studies looking at which ones do you really want to capture to make a difference. And they found out whatever is 2 or 3 are the ones that you need to capture because you can do something for them. And this was published and was validated. So the same group from Sloan Kettering looked at the validation of ESCC, and they found out there was an inter and intra-observer reliability. So when you get 10 people and you tell them, here's the MRI for this patient, 7 or 8 out of the 10 will give you the same thing. Not necessarily 2 or 3, but they will tell you, oh, this is 2 or, not necessarily 1C or 2, but they will say, oh, this is 2 or 3. That's all you want. You want to capture those, because those are the ones that will probably neurologically advance very quickly. If you keep watching 2 or 3 without doing anything, they might get paralyzed. So that's where you become effective and make a difference. All of this is just the N component. Now the O component, okay, the second letter of the NOMS, oncological assessment. You need to know what is the histology of the tumor. What is the primary cancer? Is this coming from the lung? Is this coming from the breast? Is it a renal cell? Is it a melanoma? Is it a lymphoma? What is it exactly? Why is that important? Because the radiation sensitivity is different between all of that. It gets a little bit complicated when you go into, oh, what kind of lung cancer? Okay, for example, a non-small cell lung cancer, NSCLC, has a U in those studies, which is unfavorable response to radiation. So chances are they're not going to respond only to radiation, okay? Whereas breast is usually a favorable, and lymphoma, seminoma, myeloma, very radiosensitive. Those patients, unless there's something else going on, you radiate them, it melts away. You do a follow-up MRI, it's gone. So we need to know what is the histology of the tumor because that helps. The third component, which is the M, mechanical stability. I'm showing you publications, right? I'm not making up anything. The mechanical stability can be assessed using the SINS score, okay? And the SINS score, I'm sorry, this is the Tokuhashi. I think we skipped, okay, I don't have it. Let me tell you, the SINS score is Spinal Instability Neoplastic Score. In general, in peripheral tumor, like bones, you know the Merrill's score. How can you predict that a bone is going to fracture? There is an equivalent to that, which is the SINS criteria. What is the chance that a vertebral body is going to fracture? So they looked into how much of the vertebral body is involved. Is the posterior elements, the pedicles, the facets, the PLC, the posterior ligamentous complex, is involved or not? And it's the point system. Where is it in the spine? For example, the thoracolumbar junction, where there is a lot of motion, has a very high risk of fracturing, whereas the middle of the thoracic spine, where you have a rigid rib cage, has a very lower likelihood of fracturing. So you put them together. Is it a lytic lesion or a blastic lesion? Okay, lytic has a higher risk. Is it a multiple lesions, bilateral facets, or unilateral facet? So you add the points and you come up to less than 6 is stable, between 6 and 12 is potentially unstable, and more than 12 is unstable. Of course, to complicate things, most patients, they lie in the middle, potentially unstable. So you don't rely on one single component of the NOMS criteria to base your decision. You do all of them, and then you put them together and make a decision. So that will come down to this. This is the summary of everything I have been talking about in the last few minutes. It looks very complicated at the very beginning, but neurological, oncological, mechanical, systemic, and what you can do is, the summary is, if the tumor is resistant and you have instability, then you have to do something called separation surgery and stabilization. Am I over time? I think I'm over time. I'm going to keep going fast here. So, or you need only to do external beam radiation, or you need to do a stereotactic radiation, or do not operate. The patient is too sick to tolerate surgery. So you put all of that together and make a decision where you go from there. Now, the other group, pattern group, they looked, okay, you know what, NOMS is great, but what if the patient had a previous history of radiation? What if the patient has 2 lesions? NOMS doesn't answer that question. So you have to include that in your assessment. Again, NOMS is a good roadmap, but it doesn't give you all the answers. Future directions, you need really big data. You need to look into the integration of biologic therapy, machine algorithms, and again, you need a combination of both classification systems, a big list of options of what we usually do. It can be a simple kyphoplasty, RFA, ablation, percutaneous instrumentation, plus minus cement, or anterior, posterior, anterior and posterior. Do you get bone graft, you put cement, cages, etc., etc. Very important, pre-operative embolization. Renal, Ewing, thyroid, they bleed a lot. Always, always embolize. Again, you delay post-operative radiotherapy 3 to 6 weeks or until the wound heals. It's minimally invasive surgery.
More 2-3 minutes.
Okay, so minimally invasive is an option. Basically, this is the most famous study from the group Dan Shuba. They explain how can you do this in a less morbid way. And again, you can go back to the study. Biologics, game changer in metastatic lung cancer, game changer in melanoma, and etc. We're going to go over a few cases really quickly. This is a 60-year-old female, history of breast cancer, mid-back pain, paresthesias, evolution of spinal cord compression and myelopathy. This is her CT MRI, a big lesion replacing most of the vertebral body, ESCC of 2. She has neurologically a developing myelopathy, but it's a single disease. So when we have a single metastatic lesion, we need to be more aggressive. So this lady got a subtotal corpectomy, separation surgery, excision of tumor, replacement with a cage anteriorly and stabilization above and below with cement augmentation at every single level. I get criticized, but that's how we maintain our hardware long term. And this is a follow-up CT scan, and she was fused. 37 female, mid-back pain, family history of neurofibromatosis. This is the tumor, chemoradiation. It really shrunk away, and this was an Ewing. This was a primary bone sarcoma. We utilized navigation as well as robot in this. It's very, very delicate where you put your osteotome near the spinal cord to try to do the osteotomy and take the tumor away with a negative margin. This is where technology becomes very, very helpful. So we're lucky to have navigation and robot as well. We published a review of this, and some people criticize, how can you trust a robot to put a screw near the spine? Well, how can you trust a robot to make your own car that you drive with your family? So you do trust robots, even without knowing it. This is the outcome, and I do have few cases, but I think the time is not enough. This is a lady that we did a front and back, and this, a lady with multiple myeloma, minimally invasive approach percutaneous, as well as a kyphoplasty above it. A renal cell carcinoma guy, where he had a cord compression, he got pre-operative embolization. We took all the posterior elements, so if I did this only posterior, it will not heal. So I decided to go front and back. I have an anterior support with an allograft. That healed, so I don't care about the posterior if it heals or not. So he really had very good outcome post-operatively. Another case of a metastatic breast cancer, the worst compliant patient. We do surgery, she doesn't get chemoradiation. Our work is useless. It failed. So we go back, and she didn't get any chemo for radiation, and we do a 2-level anterior corpectomy, fibular allograft. We flip her posteriorly. We go way above and below because this patient is not compliant. She will not get chemotherapy or radiation. So all of this is the only thing that's going to help her long term, and that's her a year and a half later. I think I'm going to stop here for the sake of time. Again, it's, this patient is a revision, multiple myeloma patient, and I know it looks funny, the case looks funny, but that healed. I have a post-op CT scan, and it ended up with a very good position. This lady with a history of breast cancer, same thing. This is an ESCC of 3. You have a complete displacement of the spinal cord. She was myelopathic, and she had a couple other spots on her PET scan and bone scan, and we ended up doing a double-level corpectomy above and below. Again, navigation is very helpful in those cases, and thank you very much.
Thank you very much, Dr. Montasem. Actually, what I was wishing is that this session was a lecture for 45 minutes, not just for 15 or 20 minutes. This is so much experience, so much rich experience. I believe that in discussion we may have also more opportunity to elaborate more on this subject. Thank you very much.
Absolutely.
And
thank you.
That was so much rich. Thanks.
Thank you.
Thank you, Dr. Montasem. Next lecture will be with Dr. Wali Al-Hardan, is an orthopedic oncology and complex limb reconstruction surgeon from Jordan. And he will talk us about complex resection in the pelvis, tricks of the trade. Yes. Good morning.
And can you see my slides? Can you see my slides?
Yes, yes.
All right. So good morning. I'm so happy to be here with you today. Thank you for hosting us and inviting us to this great event. My name is Walid Harden. I'm an orthopedic oncologist and an adult hip and knee arthroplasty surgeon, currently working at University of Alabama at Birmingham in the United States. It's very hard to follow such a great talk after Dr. Mutasim, who was actually one of my mentors at the University of Miami when I started to do my fellowship 2 years ago. So I'm gonna talk for the next 15 minutes about complex pelvic resections and reconstructions. So let's get started. So I trained in these three institutions, and currently I'm at UAB, which is a big university hospital in Alabama in the south of the United States. We have about 1,500 beds in this hospital. We take care of a lot of revisions, mostly in the hip, knees. I also do elbows and shoulders, and all mega prosthesis cases. So just a little bit about the anatomy in the pelvis. We all know that the pelvis is a complicated and complex anatomy structure with two innominate bones. Each innominate bone has ilium and ischium and pubis. It has also a complex ligamentous structure that provides inherent stability. This is a normal X-ray with an outlet view of the pelvis. This is how it looks in reality. It's very complicated, so many organs involved, major vessels crossing over. So when you do these cases, you should be 100% aware of the anatomy, and you should be prepared to do any life-saving procedures during the case. So we're talking here about primary bone tumors in the pelvis. So fortunately, these are very rare, but unfortunately, it's very complex when it happens, and it's very hard to treat, and patients usually have poor prognosis. When we see tumors in the pelvis, it's most commonly, it's 1 out of 3. And it depends on the age of the patient. So in young adolescents, you can expect osteosarcoma and Ewing sarcoma. In middle-aged patients with male predominance, actually, you can expect to see a chondrosarcoma, which constitutes about 30% of all primary bone tumors in the pelvis. So it's also the second most common site of metastasis after the spine. And 20% present with metastatic disease. So what is internal hemipelvectomies? So in general, hemipelvectomies are divided into 2 classifications. It's either an external hemipelvectomy, in which you take out the whole pelvis with the lower limb, and it's a type of a high-level amputation. The second type is an internal hemipelvectomy, where you take part of the pelvis and either leave it alone or reconstruct it. And this is what we're gonna talk about. If you have a type 1, you're gonna take out the ilium. Type 2, you take the periacetabulum. Type 3, you take the obturator ring. And type 4, you take part of the sacrum. And this is the Innicking and Dunham classification. It's been there for a while, everyone using it. It's easy to remember. And sometimes you also combine these types. So for example, you can take out the ilium and the sacrum. This is type 1 combined with type 4. You can take out the ilium and the periacetabulum. This is type 2 and type 3. So what are the surgical indications? We do these for primary bone tumors mostly. We do this sometimes for isolated metastasis in the setting of a renal cell carcinoma or a solitary plasmacytoma, where the literature showed that these patients, when you take out those isolated metastases, you improve their 5-year survival. And there's so many papers about that. Now, rarely for other reasons, which I mean sometimes major high energy trauma cases, some what I call actually nightmares, like a that we call these disastroplasty, and unfortunately I see these every week here at University of Alabama. This is mostly my practice here. So in these you need also to combine your skills as an orthopedic oncologist to take down part of these metalloses and like disastroplasty and those catastrophic implant failures. Sometimes you need custom-made implants, allografts, you name it. You need to have everything in your toolbox to deal with these. So when you see a patient with primary bone tumor in the pelvis, so you start, of course, with HMP, you start with imaging studies, all the basics, you do other staging imaging, and we're not gonna go through these. You also, very importantly, you should plan your tissue diagnosis and start plan the case. So when you start seeing these, as Dr. Maaya said, that it's a team approach. You need to call your buddies and set a plan. You should have an experienced MSK pathologist. You should have an oncologist, a vascular surgeon, a plastic surgeon ready to go, and of course you're going to have a general surgeon informed about the case. So let's go through some cases. I think it's much fun to discuss cases rather than just to talk about some literature. So let's start with a simple case, and we'll escalate the complexity. This is a 44 male, left buttock mass, presented for us. He was sent for biopsy. You can appreciate the calcified lesion on the left, in the left ilium, mostly representing cartilage tumor. And when we biopsied that, it came back as a chondrosarcoma grade 1. You can see the high water content in the tumor. You can also see how it protrudes out of the ilium. So this is called chondrosarcoma grade 1. Now in grade 1, there was a debate years ago about in the pelvis whether you should do intralesional curettage and just take intralesional resection in these tumors, or just take out or do a wide local resection. And I think the current treatment, the standard of care now, is to do wide local resection, because these can actually come back in a there is a really high rate of recurrence after taking these out with marginal resection. And when they come back with vengeance, and they can go to grade 2, and then the resection will be much larger. And probably, maybe some patients will present with metastatic disease already. So you don't want to go through that. You just go down there and just take it out. And this is a type 1 resection. This is another views on the MRI. Now the question in this case should we take out the acetabulum as well, or should we leave it alone? I usually prepare for everything, and we usually keep all the options available. But this is an intraoperative decision. If you don't have any imaging suggesting that there is an involvement of the proximal femur or the hip, so I'll leave it for intraoperative for an intraoperative decision. This is the tumor taken out. This is the gross specimen, negative margins. This is the patient post-op. You can see we did not touch the bone after that. We did not reconstruct the bone, and you don't need it, because what I always say is that when you leave the sciatic buttress alone, then the pelvis is pretty much stable. You don't need to do anything. This is a 22 female. She's a gymnast. She's a professional athlete. Presented to us with lytic lesion in the left ilium near the sacroiliac joint. So unfortunately, she was biopsied from the posteriorly. She was referred to us from another institution. Usually I do these lateral. I don't like to go posterior, because now you gotta take out the whole PSIS. So you should stick with the biopsy track. This is a type 1/4 resection. We use navigation for this resection. It helps you to put these actually scary screws in the sacrum. I think it's very difficult to put this screw without navigation. This is a screw that is actually in a very strange angle. That's what I remembered when we put that screw in. You take out the tumor. Now there's a small flick of bone in the sciatic buttress. She's an athlete. She's high demand. So we decided to fix her also. So we put a double barrel allograft, and usually we use pedicle screws with rods to keep these graft in place and anchor it. This is the post-op image, and the patient did well. I went back to her sports. This is a complex case. Let's go more complex with that. This is a 43 male patient. I think he was transferred to us from Puerto Rico or something. He had right leg sciatica at that moment. You can see that huge mass from the right hemipelvis. This is an MRI, very classic for chondrosarcoma. It came back as grade 3, high-grade chondrosarcoma. So in these cases, you should go wild and you should take out as much as you can, wide local resection, get negative margins. So this is a type 1 and 2. So you should take out the ilium and the hip. So for these complicated cases, actually, we do them in 2 stages. We found that cutting the sacroiliac joint when the patient is on the lateral view is very demanding. And honestly, it's not fun at all. So what we usually do that we stage him. Stage 1 will be in prone position. We score the osteotomy. We put our pedicle screws in the spine, some rods to prepare it for later reconstruction. Then we pack and close. And on the 3rd day, day 3 after that, we go back again with a stage 2 final resection. The patient will be on lateral position. And we do the tumor resection, and we reconstruct, and we flap. This is the 2nd stage. This is the patient in lateral position. You can see a very huge incision. It's an extensile. Usually, I like doing curvilinear incision from the back, and it joins the iliofemoral approach anteriorly on the pelvis, and then I take the incision down to the knee. And this is for many reasons. You need exposures for these, but why we're doing this down to the knee? Because we actually use the vastus lateralis and we rotate it to cover the implant. And this is gross imaging intra-up. You can see the tumor. You can see the dissection about behind it and in front of it. You can see the sciatic nerve isolated. And this is actually the tumor taken out with the right hip, proximal femur. So this is the beautiful work of Dr. Rosenberg, actually. I always remember when I take these tumors, I just take the tumor to him in his office. And honestly, it's really scary just because I don't want him to say this is a positive margin. It's really fun to work with this guy. And trust me, you don't want this guy to be after you in the sarcoma board. So now how we can reconstruct that. So proximal femoral replacement, we took out half of the acetabulum. We put a press fit cup, a constraint liner, and a press fit stem on the femur side. Now this is the post-op X-ray. I know this looks crazy, but this is what you need. You have to reconstruct the pelvis. Now you can argue that you can have like a custom-made implant for that, but honestly, this patient, as we thought, he needed some sort of allograft. Custom-made implants, they kind of have a lot of loosening, especially in the 5 years post-op. They can loosen up to 50% sometimes. But we use this also. but this patient got an allograft. So this is a femoral allograft, and we leave the rods long on the side of the resection, and we use the same concept of rod compression on the graft. This is another case. This is a right pelvic liposarcoma. This patient got a chemotherapy and radiation, and he also had a right hip replacement. After 10 years, he presented with what seems to be radiation-induced sarcoma on the right hemipelvis. So you need to take out the ilium, periacetabulum, proximal femur. This is him in prone position. That's why the image is flipped. The same concept, stage 1 on the left, stage 2 on the right. For this, we used actually a pelvic allograft. You fix it with plates, and you actually add a fibular strut to augment your union rate, and a proximal femur replacement with a constrained liner. This is a 23 male left buttock pain with sciatica with a lytic lesion on the left ilium. And you can see that periosteal reaction. This came back as high-grade osteosarc. This is a type 1 for resection. And we did the same thing. This is actually the femoral nerve in the middle image. When you take out the ilium, you'll be looking right at it, next to the iliopsoas. And here we used a vascularized fibula to bridge the gap and a lumbopelvic fixation to hold the integrity of the pelvic ring. Now we'll go more in a different path. This is an 80-year-old female, isolated metastatic thyroid cancer. She had a staphylodomalytic lesion, as you can see on the right. One of the interventional radiologists actually put some cement there in an attempt to minimize massive surgeries. Unfortunately, a couple of weeks ago, she had severe pain, inability to bear weight. You can see pelvic discontinuity on the right side. So we planned her for a custom-made biflanged total hip replacement. Her pain improved. She ambulates with a walker now. This is a more complicated case. This is a right hip pain. Patient, 59-year-old female. You can see that lytic lesion in the dome of the acetabulum. When you take this out, you need a type 2 resection. We sent her for CT-guided biopsy, came back as D-diff chondrosarc. These patients do very poor, actually. Most of them, as I have seen, they actually die within 2 years. But this patient was very high demand. She likes her yoga. She likes to move and walk and exercise. So we decided to go for the massive reconstruction. So we did this by 3D imaging, printing. This is showing the tumor. And this is the resection zone that we needed. By the way, that lesion in the ischium, actually, we biopsied that and came back as an enchondroma, which was weird. So we decided to keep it and not taking it out. So this is a resection zone that we needed to take. This is the jigs that we used to cut. And this is the resection, the final cut. You can see the bone removed on the right side in red. This is the implant and the fitting of the implant. And this is the trajectory of the screws planned. And this is the post-op. For the femoral side, we used a fluted diaphyseal stem and also a constrained liner on the hip. I just want to say that in these cases, you really need valuable tools. I feel that you cannot do these cases without that radiolucent table. I love the Aquamantis, which is a bipolar sealer that combines radio frequency and causes sealing in the soft tissue and coagulation. It's a very nice tool to use. I recommend it for all orthopedic oncologists. I use it for all my arthroplastic cases as well. And the LigaSure is a very nice tool to have. Now, Navigation is a very, very nice thing to have. It gives you a lot of accuracy in those screws. And you can also, if the tumor is a bone-forming tumor, you can easily see the tumor and avoid getting inside the tumor zone. Now, in conclusion, I would say that pelvic resections are a very demanding procedure and needs a multidisciplinary approach. You need to plan the resection before you even think about the biopsy. Usually type 1 and 3 do not need reconstruction, and type 2 almost always needs reconstruction. Thank you very much for your attention.
Thank you, Dr. Walid. It is a nice lecture. It is surely a difficult and complex resection of pelvis. And will be in the session of discussion. Thank you.
Yeah, thank you very much, Dr. Haddan. We are extremely delighted to have Professor Andrew Rosenberg with us today. He came all the way from the United States of America. He is a professor of pathology. He's the vice chair and director of bone and soft tissue pathology at the University of Miami Health System. He specializes in musculoskeletal neoplasms, metabolic bone disease, arthritis, and infection. So thank you very much for being here with us today, Professor.
Good morning, everyone. Thank you very much for coming. I want to start out by giving a warm and sincere thank you to Dr. Mazen, Dr. Faris, Dr. Motassim, for inviting me to participate in this conference. Also, for everyone that I have met that have made me feel very welcome and a member really of the medical family, the community in Palestine. For me personally, it's been an important experience because I've had the opportunity to meet the Palestinian people, to see Palestine through my eyes, my heart, not the bias of the media. No matter what language you use, no matter how you say it, the diagnosis of osteosarcoma usually brings forth a lot of dread and despair to both the patients and physicians taking care of the affected individual, because osteosarcoma, untreated or not appropriately treated, it is associated with a rapidly progressive, fatal outcome. I would like to start with basics. What is an osteosarcoma? Osteosarcoma is defined as a tumor that arises in the skeleton, bone tissue, and that it is a neoplasm in which the neoplastic cells have the biological capacity to metastasize, therefore it is malignant. And the phenotype of these cells is that of osteoblastic differentiation, in which the neoplastic cells make and deposit the bone matrix. Despite all the fancy advances in genetics, the diagnosis of osteosarcoma still relies on histological interpretation. Osteosarcoma is the most common primary malignant tumor of bone. I tried to present some information related to the epidemiology of Palestine, of neighboring countries, and there's really very little literature to provide numbers of the frequency of osteosarcoma in Palestine. I was able to get some data from Jordan. And you can see in Jordan, according to the data, it accounts for about 1.1% of all cancers. In all likelihood, that is a significant overestimation because the development of comprehensive tumor registries that capture accurate data in Jordan is inadequate, not taking into account many undiagnosed other more common malignancies such as carcinomas. So in the United States, where we have a relatively robust tumor registry, you can see that it's rare. It accounts only for 0.05% of all cancers, but it's an important type of malignancy because more often than not, it affects a young patient population. Osteosarcoma is most commonly diagnosed during the first and second decades of life. The second increase in incidence is in older individuals, and that's frequently in the setting of a coexisting disease, such as radiation for breast cancer, cervical cancer, in which a radiation-induced sarcoma develops, or arising in bones affected by other diseases, such as chronic osteomyelitis or Paget's disease of bone. There is a male predominance in the United States. It has a higher incidence of developing in African Americans in contrast to Caucasians. Osteosarcoma as a distinct entity really wasn't recognized until about the year 1800. And during the ensuing 2 centuries, different types of discoveries that were made. But what I want to point out is during that period of time is what happened to the prognosis. It was miserable in that 10 to 15% of patients were able to survive the disease until the 1970s when systemic chemotherapy was introduced for the treatment of osteosarcoma. That had a significant impact in outcome such that approximately 70% of patients were able to survive. But since that time, we've made little impact in the improvement of osteosarcoma, and that is really a major focus now of medicine to be able to use targeted therapy to improve outcome. Osteosarcoma, like all cancers, is a genetic disease. A mesenchymal stem cells develops a mutation that drives the biology and morphology of the tumor. And as we know, osteosarcoma, as I previously mentioned, can be associated with a variety of different disorders that predispose the bone to the development of an osteosarcoma. The genetics of osteosarcoma are important. And usually the neoplastic cells show marked abnormalities, too many chromosomes, loss of chromosomes. And it's a very complex picture. And it becomes impossible to identify what was the first driving mutation that resulted in the development of the tumor. And that's characteristic of all high-grade osteosarcomas, and high-grade osteosarcomas are the most common variant. In contrast, some of the low-grade osteosarcomas, those arising on the surface of the bone, can have a relatively specific genetic abnormality. In this instance, amplification of MDM2 that can provide insight into the diagnosis of the neoplasm. You can see some interesting data that with regards to the development of an osteosarcoma, and most osteosarcomas are large at the time of diagnosis, that each tumor has about 1 billion neoplastic cells. And each one of those neoplastic cells are prone to the development of additional mutations over time that make it very difficult to adequately treat with the forms of systemic therapy that we currently have. We still don't know what the single most important genetic abnormality is in osteosarcoma, but most studies show that most high-grade osteosarcoma have a mutation in P53, and if you remember, the P53 gene is very important in repair of damage to DNA. Osteosarcomas most frequently develop in the appendicular skeleton, especially around the knee, where 50% will be identified. And the single most common location is in the distal metaphysis of the femur, and that's because that's where there is greatest growth in the growth plate. And if you remember the growth plate, it requires mesenchymal stem cells, cell division, to produce the chondrocytes necessary for growth. Those cells are susceptible to mutation, to the eventual development of osteosarcomas. These tumors usually are large, they usually produce pain, can really achieve extremely large size, can fungate through the skin and ulcerate, and in a significant minority of cases result in pathological fracture. We can classify osteosarcoma according to a variety of different attributes. The two most important are whether the tumor is arising in bone or on bone versus the grade, the biological grade of the tumor. Is it at high risk for developing metastatic disease or low risk? Because that is what's going to determine how the patient is treated. Using that classification, the most common type of osteosarcoma develops within the medullary cavity, is biologically high grade, and requires systemic therapy and wide excision in order to get an adequate outcome. Using that classification system, 75 to 80% of all osteosarcomas develop within the bone and are biologically high grade. These tumors grow with an infiltrative pattern. They transgress the cortex, forming large circumferential soft tissue masses. They may show intraosseous metastases, known as skip lesions, which are associated with a very poor outcome. These tumors are big, they're hemorrhagic, they're gritty because of the neoplastic cells are producing mineralized bone, growing out into the soft tissues, displacing the periosteum that produces layers of reactive bone, trying to confine the steadily and progressively enlarging neoplasm. Osteosarcoma grows with an infiltrative pattern, replacing the marrow, completely encasing the pre-existing bony trabeculae. These tumors are very cellular. They show marked pleomorphism, mitotic activity, and we can recognize it or diagnose it as an osteosarcoma by the presence of cytologically malignant cells intimately associated with a mineralized matrix composed of bone tissue. Many different histological types of osteosarcoma. This is an example where we have cartilage in the bottom left, neoplastic bone on the top right. This is a cystic osteosarcoma known as telangiectatic osteosarcoma because of many of the blood-filled spaces, and when you look in the walls of the cystic spaces, one can identify the neoplastic cells associated with the neoplastic matrix. This is in contrast to a low-grade surface osteosarcoma, tending to arise in a slightly older patient group. Also likes to occur around the knee, but in distinction to most osteosarcomas, they have a low risk of systemic spread. So it's a disease treated by surgery and not systemic therapy because of the good outcome. And this is the cartilaginous cap that can occur in a power osteochondroma, causing it to mimic other neoplasms. This is the very well-formed neoplastic bone that's associated with the neoplastic cells that don't show marked hypercellularity, cytologic atypia, or mitotic activity. And they are intimately related to these long streamers of neoplastic bone. The surface osteosarcoma, which is at the top of the screen, can infiltrate the reversion systems of the cortex and grow into the bone, making surgical removal more difficult and challenging. And as I mentioned, this type of osteosarcoma has a specific genetic abnormality that can facilitate specific diagnoses. Genetics, being able to identify mutations, is now becoming an extremely important component of diagnosing all kinds of tumors in all organ systems. Osteosarcoma is generally a high-grade tumors are treated with neoadjuvant therapy, meaning the patient receives the drugs before the tumor is excised. Many different cancers throughout the body are now being treated that way, and osteosarcoma was the first to develop that mode of therapy. The tumors are usually widely excised, depending on its proximity to major nerves and vessels. It may require an amputation. More frequently than not, these neoplasms are excised in a limb salvage fashion. The affected bone is removed with negative margins, and then a variety of different ways can be used to reconstruct the surgical defect. Since the patients receive preoperative therapy, one of the rationales behind that is to see if the tumor is sensitive to the drugs. So we carefully sample the neoplasm, look at it under the microscope to see whether the tumor cells still alive or dead. And these are examples of successfully treated osteosarcomas where the tumor bone matrix still persists, but all the neoplastic cells have undergone necrosis. A variety of different factors can influence the prognosis of osteosarcoma. You can see that the best ones are low grade and arise on the surface. Currently, for high-grade osteosarcomas, one can expect a 5-year survival rate of approximately 70%. One of the most important prognostic features for osteosarcoma is its response to systemic therapy. Those patients that have a poor response, and a poor response is defined as anything less than 90% necrosis, have a worse prognosis. Those patients who eventually die of disease, they die of significant pulmonary metastatic nodules. And a small but important percent of patients may die of the complications of systemic therapy. The goal, really the future with regards to treating osteosarcoma, is to improve the surgical techniques, to be able to take the tumor out, preserving as much normal tissue and function as possible, but very importantly, to be able to develop targeted therapy. You can view the mutations in osteosarcoma like a conductor of an orchestra, telling the genes of the tumor cells what to do, to activate or inactivate the different cell signaling mechanisms that are active, with the goal to be able to target those that the osteosarcomas rely on to be able to successfully treat the patient and cure the individual. Thank you very much.
Thank you very much, Professor, for the interesting talk.
Thank you, Doctor. Now we move to the speech of Dr. Ahmed Shhadi from Jordan King Hussein Cancer Center to speak to us about the long-term outcome of limb salvage surgery for malignant bone tumors, review of 210 patients in a single institution. Thank you.
Good morning, everyone. Hello? Good morning. Can you hear me?
Yes, yes, you are here.
Okay, thank you. First of all, I would like to thank the organizers and the scientific committee for inviting me to participate in this conference. This morning, I will share our outcome in limb salvage surgery. But before that, I'd like to talk about the principle and the technique of limb salvage surgery. When we say salvage, what do we mean by salvage? Salvage, it is a French word. It means to rescue a property in danger. The property here is the limb. The danger is the tumor. So we are rescuing the tumor, the limb, from the tumor. In oncological terms, it is the resection, bone and soft tissue sarcoma, which leaves a painless and functional limb. There are three basic principles of limb salvage surgery. The first one, limb salvage surgery should not increase the risk of local recurrence in comparison to amputation. The second one, it should not affect adversely the patient survival and should provide the patient with a functional limb which is at least as functional as an amputation with external prosthesis. How we can perform limb salvage surgery? There are three main steps in the resection that we need by oncological resection to resect the tumor in one mass, in one piece, no fragmentation, and we don't go through the tumor cavity. There are three types of oncological resection. We have the marginal resection, where we resect only the tumor, and this is good only for benign tumors. We have the wide excision, means that we resect the tumor, we resect the reactive zone, and we resect a normal tissue from all around the tumor. And this is the type of resection that we use in managing a low-grade and high-grade bone sarcoma. And the third one is a compartmental resection. And here we resect the whole compartment from origin to insertion. And by resecting the whole compartment, and this is good also for the recurrent tumor and for multifocal intracompartmental tumors. The second step, limb salvage surgery, is doing a durable and stable reconstruction.
دكتور أحمد أسفين على المقاطعة. السلايدات مش عمالنا بنشوفها.
أنا
لسه أنا بنشوف السلايد الأولى بس.
هو أنا عامل سكرين شيرنج معلش. بعرفش بتحب إني أوقف الشيرنج وأرجع أعمل شيرنج مرة ثانية؟
غلبك أيوه عمل شير للسلايد. في سلايد شيرنج.
اوكي هيك بينوا السلايد ولا لا؟
نستنى لانك عمالك تعمل شيء يعني
يكبس اللي بده يكبسها هاي
F5 دكتور على الكيبورد.
اوكي
او ستارت سلايد.
شايفين سلايدات بس ما بيتحركوا. خلينا نعطي دكتور احمد احنا شايفين سلايداتك بتتحركوا موفينج. هي معك
دكتور يعطيك العافيه. على الشيرنج اذا في عندك اكثر من خيار سكرينز اختار سكرين الفول سكرين.
هلا انا اوريدي انا حطيته على فول سكرين.
انت عم تشتغل على شاشه واحده دكتور ولا؟
بعرفش from where shall I continue? Maybe how to perform a limb salvage surgery. We have three important steps to do a limb salvage surgery. The first one is to do an oncological resection of the tumor in one piece and with all around normal soft tissue envelope. We have three types of oncological resection. The first one is the marginal excision, and this resection of the tumor only. And this is good for tiny tumor only. The second type is wide excision, and this includes resection of the tumor, the reactive zone, and a normal soft tissue all around. And we use this for low-grade and high-grade sarcoma. The third one is radical excision. We resect the whole compartment from origin to insertion. And this is good for recurrent tumors, for multifocal tumor in the same compartment. The second step is doing a stable and durable skeletal reconstruction. After we resect the tumor, we need to replace that part of bone with a reconstruct. We have two options for reconstruction. The first one is biological reconstruction. The examples of that, autologous bone graft. Autologous bone graft, it means that bone graft taken from the same patient, like vascularized and non-vascularized fibula are good example. Structural allograft, it means a cadaveric bone taken from a dead person being processed and managed in a way to be inserted or implanted in our patient. And the third one is recycled bone. Recycled bone, we mean we take the same bone which contains the tumor, we treat it either with the cryoablation, autoclaving, or radiation, and re-implanted that in the same patient. This kind of management, recycled bone, is common in Far East and in South America, but it's not popular in Europe or in North America. The second major category of reconstruction is doing an endo prosthesis. We have three major types of endo prosthesis: the medular implant, the expandable implants, and the joint sparing or patient-specific implant. For the medular implant, already implant, these implants come in a different anatomical location. They are ready to be implanted in the patient, and intraoperatively, we can adjust the length of the implant by adding or removing segments. And by this, we can adjust the implant to the size of the bone defect. The second type is the expandable implant. We use them in children because they are still growing. We need to elongate these kinds of implant. And elongation can be either in the clinic with no anesthesia, or intraoperatively in some types of the implant. We need to take the patient back in the OR to elongate them after surgery. The third type is the joint sparing or patient-specific instrumentation. And in this type of the implant, if we have a tumor in the bone and this tumor is away from the joint or the epiphyseal plate, then we can resect the tumor and preserve the growth plate and the joint. By preserving the growth plate and the joint, we will not need expansion anymore. And we have two types of this implant: the flat surface implant and the one with short stem and the crossed screw or banana-shaped stem. The third step after doing the resection, doing the reconstruction, we need to do soft tissue coverage. Soft tissue coverage is very important for increase the durability of the limb and for improve the function by reinsertion of the important tendinous structure to the implant for function. Now going to discuss how the outcome of limb salvage surgery. From 2006 till the end of 2021, we received 244 patients of aggressive bone tumor at King Hussein Cancer Center. Out of these, 34 patients, they received primary amputation, and 210 patients received limb salvage. First, I will talk about those patients who were unlucky and they received amputation instead of limb salvage. What was the reason? This patient, 17-year-old, had swelling in the left leg. He was thought by an out facility as this is a deep venous thrombosis and was treated by anticoagulation for 1 year till the tumor became very aggressive and we cannot save his leg. This is another lady with fungating tumor in the proximal shoulder or humerus, and also she presented late to us and we did an amputation for her. This is one example how surgeon can make harm to the patient. She received dual incision biopsy, one from the medial and one from the lateral. This makes limb salvage not possible due to the multi-compartmental contamination. This is another ops surgery for a child with proximal femur Ewing sarcoma. Was
اختفى الصوت دكتور أحمد.
I think that osteosarcoma is very aggressive tumor pathology that need to be treated early. Late presentation was seen in 18 patients, and this is lead to multi-compartmental disease, complete neurovascular encasement, and tumor fungation. Inappropriate surgery at outside facility. This is the second major cause for losing the opportunity for limb salvage, and this is done by physician. See, we need to be very cautious in managing bone tumor in children. Now we'll come to patients who received limb salvage. There are 210 patients. So 86 of all bone sarcoma at King Hussein Cancer Center, they have limb salvage surgery. Out of those, osteosarcoma was the commonest, and it is almost half of the patient with limb salvage surgery, followed by Ewing sarcoma in 20% and metastatic tumor in 6.7%. For the location, distal femur was the commonest location for limb salvage, followed by proximal tibia, proximal femur. The reconstruction modality that we use in our center, Endo Prosthesis is the commonest. We use it in 92%. Modular implants is the most common modality of Endo Prosthesis, followed by joint sparing implant and then expandable implant. For bone allograft or autograft, we use it only in 4%. No reconstruction in 4%. No reconstruction such as a tumor of the fibula or type 1 pelvic resection. We don't need to do reconstruction in these subtypes. Our outcome were measured based on the oncological outcome and patient survival, functional outcome, complications encountered, endoprosthetic survival, and limb survival. For oncological outcome, we have 15% had local recurrence. Half of them, the local recurrence was associated with systemic metastasis. What we did for those who have local recurrence, the majority of them, no further surgery was done and were treated in the context of palliation. Half of them had wide local excision and other half amputation. Our 10-year overall survival for all patient histopathological subtypes was 70%. For Ewing sarcoma, the 5-year survival for those patients who did not have distant metastasis or local recurrence was 83%, and for those with local recurrence was only 33%. The percentage was very close for osteosarcoma. So we can see that local recurrence, it heralds a poor outcome. For the function score or functional outcome, we measure it using the MSTS ISOL's function score. It is out of 100 score. The best result was achieved for joint sparing endoprosthesis in 93 to 100 percentage ranges, followed by distal femur and then proximal tibia. This is one patient with proximal tibial replacement. We can see this is the tumor resection in one piece, and here the modular implant that we use. This is the function of the patient 3 months after surgery. We can do straight leg raising and flexion, and we can see that we preserve their peroneal nerve function. And this is the function of the patient. This is another patient with bilateral distal femur osteosarcoma. It's extremely rare to face a bilateral osteosarcoma in the distal femur in oncological practice. We did bilateral distal femur replacement to here in both knees, and we can see here function 3 years after surgery. This is another patient with proximal humerus osteosarcoma. He received a reverse shoulder arthroplasty in the right upper limb. You can see the function in the right upper limb almost comparable to that in the left side. Internal rotation and abduction. For complication encounter, no, the majority of our patients did not develop any complication, almost 73%. 8% only have mechanical complications, superficial skin infection in 7%, and periprosthetic infection in 4%. Stem loosening was the most common leading cause for revision in 36% of our revisions. Periprosthetic infection was the second, and periprosthetic fracture the third. For implant survival, we found that at 10-year survival of the implant, almost 80%, and it was comparable for all three subtypes of the implant. Limb survival or secondary amputation rate, it was, we have 9 patients who received secondary amputation out of the 210 patients. 5 of them for tumor recurrence and 3 for periprosthetic infection and 1 for soft tissue ischemia. So overall limb survival at 5 and 10 years was 92% and 90% respectively. We compared our results to the previously reported literature. We found that we have a comparable outcome with the outcome in the developed countries. Even we have an amazing outcome regarding the function, was 90%, and regarding the incidence of secondary amputation, it was only 4%. Secondary amputation incidence, it indicates that you are not only capable of doing limb salvage, you are also capable of preserving the limb when complications happen. So in conclusion, this is multiple outcome study were measured. Negative margin was achieved in 97% of patients. Average functional score was 90%. There was no difference between the 3 main types of the implants in the medium and long-term outcome. Sorry. Most of the patients with endoprosthetic reconstruction, almost 3/4, received only the primary surgery with no subsequent complications. The 10-year follow-up limb survival was 90%, and patient survival on average was 70%, making limb salvage is a favorable approach to be used in a developing country when the needed resources and well-trained surgery team is available. These outcomes were commendable and comparable to those published previously in developed countries. Thank you for listening. I'm ready to receive any questions or comments.
Thank you, Dr. Ahmed. Any questions, Dr. Ahmed?
Thank you very much for your very important lecture. I noticed that the majority of your cases is distal femur. If we go a little bit higher at the upper end of the femur or in the pelvis for such sarcomas, we will start finding another sort of complications which are simpler than the one you have said, like lymphedema, lymphoria, and deep vein thrombosis. Possibly you and the previous lecturer can comment on how much lymphedema and DVT occur in these patients post-operatively?
Okay, if I understand the question correctly, you are asking about other complications other than the one which I mentioned. Yes, we have other complications which are very minor and have low incidence, and maybe due to the limited time, we cannot mention every single details about our complications. However, we are publishing data now in one of the PubMed journals. For deep venous thrombosis, as I can remember, it happened only in one patient out of 210. We should know that this surgery is performed most of the time in pediatric patients, so the occurrence of DVT is less. And something else that sarcoma patients, propensity to develop deep venous thrombosis is less. For swelling or lymphedema, actually this is very transient. It can occur in the first month and then it will disappear, but we do not have definite statistics for this because it's a transient and usually we don't do treatment unless it was severe. And bone sarcomas, usually we don't have a problem of this. We have it more in soft tissue sarcomas, especially operating in the medial compartment of the thigh. We can end up with seroma and with lymphedema.
Thank you, Dr.
I
Ahmed.
hope this answers your question.
Thank you very much, Dr. Ahmed. I'm asking Dr. Mazen if we, what's now the plan?
We are just for questions that we are skipping the last discussion group because.
Okay, so 4 questions for whom?
Questions. Anyone who want to ask questions for Dr. Ahmed or Dr. Mu'tasim or Dr. Andrew?
Okay, now we are opening the questions for Dr. Maaya and Dr. Rosenberg. If anybody is having any question or discussion. Actually, I may start with one question to Dr. Maaya. Thank you very much. It's about having like a patient with prognosis less than 6 months, life expectancy. I'm not sure if such patients may be still having potential mechanical instability and not are in a mechanical instability. For these patients, as an example, are you going to go forward for a palliative, maybe non-invasive, minimal or minimally invasive surgery for stabilization to keep life quality still, although they are just a 6 months period?
Yes, very good question. And this is one of the drawbacks of those classification systems. They don't cover this subgroup of patients. So for those patients, we try to do, very little, very little procedure that can help them. And the most common procedure that we do, me and sometimes I send it to interventional radiologists, is vertebroplasty or kyphoplasty. The problem with advanced cases is patient selection with vertebroplasty and kyphoplasty. So, and oftentimes interventional radiologists will get in trouble and they call us, for emergencies because there's some contraindications for those patients. And the most common thing is involvement of the posterior wall of the vertebral body. So if you have complete involvement of posterior wall of the vertebral body, you put cement, the cement will displace the tumor backwards.
That's right.
So you either have a cement leak or you have displacement of tumor tissue into the spinal cord, and then the patient wakes up with paralysis or weakness. So you have to be very careful. Multiple myeloma, they usually, it's a bone marrow disease, it's everywhere. you have fractures at multiple levels. So that's the most common thing that they get. But with multiple myeloma, the lateral wall and the posterior wall of the posterior body is so weak. And those patients, we get leakage all the time. The problem is if you have good radiology assistant that shows you a good x-ray, whenever you see some leak, you stop right away.
But will you go for minimally invasive surgery for these patients?
Absolutely.
Like proximal and distal?
Absolutely.
Yeah.
So one of the cases that I showed is an 80-year-old female with multiple fractures. One of them is completely collapsed, so vertebroplasty is not an option. So I go with percutaneous instrumentation above and below, and I cement my screws so that they don't come out, which is the most common side effect or complication in stabilization in those patients. Hardware failure and pull out. So we do percutaneous minimally invasive instrumentation for those cases.
Thanks. And about the cannulate, are these screws cannulated screws or porous screws? I mean, before when cement was just applied and we are afraid of being dry before the time that we are putting a screw. Now, are these screws just cannulated or they are porous?
They're cannulated.
Tethering parts so that cement will go into the pedicle, I'm not sure.
Yeah, they're all cannulated screws. So we go percutaneously, minimally invasive, where we put a Jamshidi needle in first. We take the trocar out. We put a wire down, a K-wire. We take the cannula out, and then we put the screw in. And then the cement filling tool will go inside the head of the screw. So there's nothing that goes anywhere. And we have a sign, a colored line. If the line is not well seated, that means that you're not in the head of the screw. So you cannot put cement until you make sure that it is well seated. This is percutaneous. This is minimally invasive, so you're not looking. So everything is done, outside the body. So very little things, simple, but one mistake can be very expensive.
Right. Thank you very much. If there is any question for Professor Rosenberg or Professor Maaya, maybe I'm having another just little question for the last. Dr. Afan.
No, thank you. I've actually got a question for Professor Rosenberg. It's actually inspired by the talk of Dr. Ahmed Shahade about limb salvage surgery. It's just, how often do you get frozen section diagnosis requests for these kinds of surgeries? Because I've personally got no experience with that. I just can't imagine what kind of a nightmare it would be for a pathologist to receive these samples, especially after chemotherapy. So would you just
sure,
your experience
I will
on that?
expand my answer with regards to utilizing frozen section in musculoskeletal pathology. First of all, we frequently do frozen sections on needle biopsies to confirm that we have diagnostic tissue. And we work very closely with the orthopedic oncologist. So when they remove a tumor, they usually bring it to the pathology laboratory. We dissect the specimen after they explain to us in detail the orientation, so I understand where and what are the different margins. We then usually cut it right then and there through the tumor and its relationship to the closest margin. And if I feel that it's extremely close, and if I identify through a conversation with the surgeon, if I ask them, if this margin is positive, are you going to take more tissue? I will do a frozen section for confirmation. Otherwise, if there is a significant distance visually between tumor and margin, I don't do a frozen section. When it's close and I need confirmation, I will do a frozen section. So they're commonplace.
Yeah, thank you very much. Thank you. Any more questions?
I think we are finishing this session. Thank you very much. I'm not sure if there is a coffee break or we're going to start hepatology immediately. كيف دكتور؟ So we are sorry you need to keep in the stage so that we can start immediately for the hepatology session because there is no time and we need to time for prayer. Again, thank you very much, professors and doctors, for your presentations and coming here to Palestine.